Hello, everyone. Welcome to the National Keratoconus Foundation evening webinar. Our topic for today is cross-linking for keratoconus, better with more bonds. And we have two fabulous speakers joining us tonight. We have Dr. Michael Greenwood and Dr. Brooke Messer. I'd like to give you a little bit of background on each of them first before they start. So Dr. Messer received her Doctor of Optometry degree from the Southern California College of Optometry. She then completed a cornea and specialty contact lens residency at the same institution, and coincidentally, I also completed my residency in the same program, so we went through some similar training. She joined the Vance Thompson Vision team in Fargo, North Dakota in 2020 and is focusing on the management of cataract, glaucoma, cornea, and refractive surgery. She routinely manages patients with keratoconus and post-surgical corneas using corneal, scleral, and specialty contacts, and has a special interest in myopia control and orthokeratology. Outside of work, she and her husband stayed busy chasing her two children. She enjoys golfing, fishing, and visiting family back in her hometown. She works alongside Dr. Greenwood, who is also here with us today. He is an ophthalmologist specializing in the cornea, obviously does corneal procedures and surgery, including cross-linking, and works very closely together with Brooke Messer at the Vance Thompson Vision Center. So just a few housekeeping items to the audience. Please feel free to enter any questions that you may have in the chat. We will be going through the questions and answering them midway throughout the presentation, as well as when at the conclusion of our lecture. Yes, our lecture will be just about an hour, and I'll quickly introduce myself. My name is Gloria Chiu. I'm an optometrist at the USC Roski Eye Institute, and I will be moderating our session this evening. So without further ado, I am going to turn it over to Drs. Messer and Greenwood.
Thanks, Gloria. That was a nice intro. Even though Mike and I sit across from each other, our offices are, within earshot of each other. I'm actually closer to you today. I'm in Silicon Valley, close to Google. So I'm here on a nice day, enjoying the sunshine. And thank you for inviting us to talk with you tonight, or with all of you, in fact.
Let's see.
So tonight we're just going to go over a few things. First, we're just going to do a quick cornea and keratoconus review. I'm sure that many of you who are joining tonight are somewhat familiar with keratoconus and really looking for the meat of the conversation to be on the topic at hand, which is corneal cross-linking. So we're going to talk about the process of corneal cross-linking and what you can expect after, pre and post-operatively. And then we'll have a couple spots for questions during our chat tonight. So just a quick intro to the cornea. It starts with the tear layer at the very front. The tear layer provides nutrients and washes away waste, and it provides a clean refracting surface. We need a clean windshield, and so when you have a nice clean tear layer, you're going to see your best. That's followed by the epithelium, which is basically the barrier, like the skin of the eye. We actually remove the epithelium during corneal cross-linking. Next is Bowman's layer, which is a membrane that separates the epithelium from the underlying stroma. And the stroma is kind of like the muscle or the meat of the cornea, and that's the bulk of the cornea structure, about 500 microns thick. And that's where keratoconus occurs. And so we're focusing our treatments and understanding on keratoconus on the stroma. And then that's followed by the endothelium, which is the innermost layer, which has little pumps to keep the cornea clear and free from swelling and fluid.
And, as Brooke mentioned, the cornea with keratoconus, the part that's affected is the stroma or the meat, but what it does is it changes the shape of the whole cornea, which you can see down in that bottom left-hand picture. And the cornea is a very, we'll call it kind of OCD. It's got to be very regular. Everything's got to be nice and aligned. It likes to be a certain thickness. If it gets too thin, it starts to bulge, like in keratoconus. If it gets swollen, it can't be clear, and then it gets kind of cloudy. And sometimes when you get scarring, or if you get really bad keratoconus, you can get these breaks in Descemet's membrane. It causes swelling, and that's where the cloudiness can occur. So the cornea likes to be nice and regular. It likes light to get through it. And as you can see on the slide here, normal thickness is right around 550 microns. The patients with keratoconus, their corneal fibers are weak and damaged, and so that's why it kind of bulges out. And sometimes it's like that picture there where the we call it like a nipple cone, where it's almost like a triangle, but usually there's a little bit of sag, and so sometimes I like to refer to it as like a beer belly, where the bottom of the cone is protruding a little bit more. And when the cornea isn't nice and round, that's what we call irregular astigmatism. That's why people get such fuzzy and blurry vision.
So keratoconus is from a family of conditions called corneal ectasias, and ectasia is that description of where those fibers in the cornea, they slip past each other, they stretch, which causes the cornea bulging. In fact, I've always found it interesting that the cornea fibers actually extend out onto the sclera, and they're the same fibers. It's just the sclera, which is the white part of your eye, the fibers are mixed up and messy, and that's why it's white. And once they hit that cornea, all of a sudden they all get in line and behave, if you would, providing that corneal clarity. When those fibers slip and stretch, that causes that corneal thinning. Some say that we lose fibers, some say the fibers stretch and again slip past each other. And actually keratoconus begins on the posterior cornea, which is why it's important that when you have your keratoconus screenings, if you're concerned about yourself or a family member having keratoconus, that you have what's called a tomography done. Many offices out there have a topography, which scans the front of the cornea shape, but it's important that you have a tomographer which can get to the back of the cornea. Keratoconus is progressive. That's just the nature of the condition. And so even if you have it and you're a perfect patient, never rubbing your eyes and treating your eyes perfectly, it still tends to get worse. And there's mixed inheritance patterns. So just because you have it doesn't mean your kids will. Some families it's very strong, those genes are very dominant, and then in other families it's more mixed from a I have families where both parents have it and none of their kids do, and then I have other families where the entire family has it. So we see mixed inheritance patterns.
Yeah, and I think that's important to recognize. There's a lot we know about keratoconus, there's a lot we don't know about it, and we know the fact is that it's progressive without treatment, and that you can have mixed inheritance patterns, but because someone in your family has it doesn't mean that you're going to get it, but it does make you a lot higher risk. So it's something that needs to be on your radar. And going back to what I was talking about before, it is progressive, and the purpose of our talk is to kind of talk about the treatment part of it. And so without treatment, it'll continue to get worse, and we'll kind of go through that here shortly.
I can keep. Yep. Keratoconus starts in the late teens or early 20s, but that doesn't mean it can't show up later. There is evidence that it can show up even into the 40s with hormonal changes or injuries. So if there's changes to the cornea shape, we're not going to not call it keratoconus if it shows up later. Patients typically first notice that they get blurry vision and they change their glasses often. Patients typically are heavy eye rubbers, heavy habit there. And there may be some additional allergies, asthma, or connective tissue disorders.
And the only other comment I'll add on this is, we have written patients often report eye rubbing, but a lot of times patients don't realize that they're doing it. And so if you're someone out there listening and you have keratoconus and you're not sure if you rub your eyes, just ask one of your friends or family members, say like, hey, do I rub my eyes a lot? And they'll know. They'll either say, no, I've never seen you do it, or they'll give you a resounding yes, like, I can't believe you're asking this question, you do it a lot. And a lot of times in the clinic, we'll ask the patient, hey, do you rub your eyes? But then we look at whoever's with them in the room, because they're always over there going, yes, absolutely. And then the patient usually says, I don't think so. And then they get in there and they rub their eye. And so,
or I was gonna say another time that people, or that at least usually women rub their eyes that they don't know, is removing eye makeup. And so that's another thing that I like to address from the exam room is, how do you remove your eye makeup? Where are you rubbing? where are you putting that pressure?
And we call it pillow diving because we don't have a better name for it. But you'll see, animals do this if you've got animals, but a lot of times we do it when we go to bed too. If you always sleep on your right side, you'll kind of rest your head in and really kind of, get in there real good. And as long as you're rubbing on the bone, that's all fine. But sometimes people really get in there and do it. And that's why keratoconus isn't always balanced between the two eyes. If we're rubbing one eye more than the other, or sleeping on one side more than the other, where you're rubbing your face or the eye and the pillow, that can cause changes as well. Let's see if I can advance here. And so we touched on this a little bit on how does it affect vision, but basically it makes it less clear. And when you have a nice, perfect cornea, the light comes in, it focuses on the back part of the eye or the retina, and you get good vision. But when you have keratoconus, instead of it being nice and smooth, it's a little bit warped, and so that bends light in different ways, and that can cause trouble with your vision. The same way as if you have your glasses on and you take them off your eyes and kind of move them around, it bends light a little bit. Or if you've got like a piece of plastic that you've kind of moved around in front of your eyes and it bends things, or if you went to a fun house and went to a magic mirror where it's not a smooth mirror, that's where you get that blurring and distortion or doubling of images. And the same thing is happening with your eye, with the cornea and keratoconus. And so how do we diagnose it? We've talked about this a little bit, the history, asking about it. But when we take a look at your eyes, if you have to keep getting glasses changes, your astigmatism is getting higher, or your nearsightedness is getting worse, you're not able to get to the 20/20 line at the doctor's office, or some of the other things listed here that the doctor will do. They use a light to look, or when we use a magnifying a microscope or our slit lamp, we can see different things, and we'll give examples of those here. This is kind of what it looks like when we look in your eyes. And Brooke, maybe you want to describe what's going on in some of these pictures.
Yeah, so the top left picture is what we would see on what we call retroillumination, or with our retinoscope. We could see it in both ways, but you can basically see the outline of the cone there with the light bouncing off the back of the eye and highlighting that irregularity in on the cornea. And this is a way that your optometrist would do it, maybe at your routine eye exam if they don't have a tomographer. This is a pretty advanced case of keratoconus, and it's harder to pick up on those early mild cases. But sometimes we can see it with retroillumination. The picture below that is what we call vote striae, and it's basically little, breaks or stretches in Descemet's membrane, which is, the inner layer to the endothelium, and that's a, diagnostic. If you have this, you basically have keratoconus, so that's a pretty common finding. And then the last two pictures are a little harder to see, but there's a little iron line that kind of settles at the base of the cone, and that's a Fleischer ring, and that's the iron from our tear layer settles around that junction of where the cone starts on the cornea. And so these are all things that if we see it, we know that we're working with a cornea that has keratoconus.
Yeah, very good. And just a reminder, if you're listening in and you have questions, you can type them in the question section or in the chat part, and we'll get to them about halfway through, and we'll also have time at the end here. Keep clicking one of the wrong buttons. There we go. So how do we diagnose it? We used to do it just how we explained with the physical examination, but as Brooke mentioned, you'd have to get it pretty far advanced for us to pick up on it. But as technology is kind of advanced, we've got these other options to take a look. You've heard us say the word topography or tomography or now pachymetry, and basically what that means is topography is just an elevation map of the front surface of the eye, and it's very similar to a map that you remember from school where you'd look at an elevation map of a landscape. And this is just anterior cornea imaging. It's helpful, but it's not, sometimes we get tricked by it a little bit because there's different things that can be going on the front part of the eye. And as we touched on a little bit earlier, the disease process kind of starts on the posterior cornea. So what we really like to use is this tomography tool, and that's what you see up here. A lot of times you just hear us call it a pentacam. That's the brand name, or one of the brand names that's available. But what it can do is the upper left picture here, that's kind of the topography, so to speak, and the purple is flat and the red is steep. So this is someone who, if you use your imagination, that's got beer belly kind of coming out of the screen towards you. The posterior views on this are on the more right-hand side, and in this one we've got the let's see, the bottom right one with kind of the circle and the purple there. That's kind of the posterior float, which isn't important for this talk, but basically it's showing us that the posterior part is bulging a little bit more than the anterior part, and that's why we're having the problem. And then the bottom left picture is what we call pachymetry, and that's how thick or thin the cornea is. Again, a normal cornea is right around 550 microns, and if you can see the numbers on the screen there, the thinnest spot there is under 450, so it's a pretty thin cornea. So again, it's just kind of that bulging of the cornea coming out. So this is what our biggest screening tool and diagnostic tool is, and you know, if we didn't have this in the clinic, it can make it a little bit more challenging to diagnose keratoconus early on, and that's when we really want to catch it, because we can treat it now, and if we can treat it, we can keep the good vision you have, versus waiting for it to get worse and then having to you know, kind of be stuck with that vision. Other tools we have, anterior segment OCT, that's that picture on the far right. So again, you can see that's not a very normal arc. It's kind of got that kink to it where it's very thin in that one section, and it's got a positive, we call it a, you know, positive diagnostic sign because someone drew a arrow on it, but it shows how thin that cornea is there. It's only 350 microns. And more recently, we've had access to genetic testing where it's not a true like yes or no, you have keratoconus, but it pairs a lot of the genes that are risk factors for keratoconus, and it can kind of stratify that risk. And so if someone, like on this picture here, they've got a 77, it's just a scale that gets set from 0 to 100, 0 being low risk, 100 for highest risk. You can kind of figure out where you are on that path, and that's helpful for families. We use that quite a bit in clinic. And then the aberrometry, which is basically a fancy word for saying how light gets bent across the cornea. If it's very irregular, you know, that raises a flag for us. And then the contact lens testing, where you can see where the fluorescein, or in this picture the green stuff, is kind of pooling, and if it's pooling in a particular pattern, we can figure out where the keratoconus or what patient may or may not have keratoconus. And so, Brooke, I believe this is a case of yours, so I'll let you.
I was just gonna comment on a couple different scans. You know, that keratoconus isn't really clear cut. You know, patient one, a little more obvious. We have that inferior steepening. And on the bottom right corner, that posterior one does have a little bit of bowing, and the bowing the shape of the bowing kind of matches the front. Even though their cornea thickness is fairly average, you know, I would say this patient probably has, you know, mild-ish keratoconus. Patient number two is a little bit tricky. You know, the Ks are a little steeper. 47 is a steeper keratometry reading than what we see in most patients. The cornea is a little bit thin, less than 500 microns, and there's a little tiny hot spot in that bottom right picture. So this patient to me is maybe like what we call form fruste or preclinical keratoconus. I would worry about something like this if this patient came in wanting to have LASIK. I would maybe, you know, do some of that genetic testing or other instrumentation that we have in the clinic just to learn more about how this cornea is shaped. And if you want to go to the next slide, Dr. Greenwood, I added this one just before we launched the webinar tonight. This was a patient that came through the clinic today. You know, this is kind of a wacky looking cornea. There's that inferior steepening, but doesn't have that typical cone. The posterior elevation has some thinning hotspots there. This patient is a 47-year-old Caucasian female, corrects to 2015. She's low on the keratoconus risk there, that 33 for her genetic testing. She came in like 6 months ago. We wanted to monitor, and she came back today for repeat testing. And that's why we got that genetic test. But still, you know, there's just a little bit of suspiciousness going on here. And so again, keratoconus is not clear cut in that everybody's cornea looks a little bit differently, or a little bit different. And you know, this may even be the cousin of keratoconus, you know, developing into something like maybe pellucid marginal degeneration.
Right. Yeah. And as you mentioned, you know, everything's on a spectrum, and the whole, you know, when we get into the treatment thing, you know, we want to treat early rather than waiting, because again, we can save the vision that we had. And what I'm referencing is before we had a good way to diagnose it with the topography, tomography, and pachymetry, we didn't even really have a way to treat it very good that would treat the disease process. We could treat the vision, but we couldn't treat the disease. And what you would end up with is what you see here. And this is a full thickness cornea transplant. And before we would, you know, we'd diagnose it very late. We would give them glasses, then, you know, rigid contact lens, or then a scleral contact lens. And then once they just couldn't function anymore, that's when we went into the full thickness cornea transplant. And most of the time you end up, you know, in a scleral or some form of custom contact lens anyways. And now you've got all the things you've got to worry about with a cornea transplant. So one of the beautiful things, and probably the most impactful treatment that we do now in our practice, is the cornea crosslinking to, you know, halt the progression and avoid cornea transplants. Cornea crosslinking got approved in 2016, and before that, you know, we would do, you know, quite a few full thickness transplants for keratoconus, and now the only reason we really do full thickness cornea transplants is from ulcers or injuries or something like that. We almost
old keratoconus patients
don't do it. Yeah, yeah. Yeah, repeats on previous patients that needed them. We just really don't do it anymore, and that's one of the most beautiful things that we have. And so, you know, we kind of talked about most of this stuff, but it's really crucial to diagnose early, treat before vision gets lost, and keep you in your glasses or soft contact lens or your specialty contact lens if you're there. And then of course we talked about, you know, eye rubbing, pillow diving, and treatment of the allergies.
And I think one of the most important things in the way that I've changed, you know, when corneal crosslinking was really gaining speed when I left my residency back in like 2010, 2011. And back then we were still a little hesitant about corneal crosslinking, you know, definitely learning more. And it was still one of those things where it was like, prove to me that the cornea is changing before you do this. Where now, you know, we crosslink first, vision second, where back then it was vision first and then maybe crosslink if things were changing. And so I think that's the biggest shift in the last decade, is that, you know, we have to tell the patient, sorry, you need to wait another 3 months to have your vision corrected if they were looking to maybe get into special contact lenses, because it is most important that you have the corneal crosslinking prior to getting contacts. Questions that I get from patients when they come in for a pre-op is, you know, if I wear hard contact lenses or a scleral, does that keep my eyes from getting worse? And the answer is no. Really, the only thing that stops the progression is to have corneal crosslinking.
Right. So let's get into the treatment chunk. And so you're going to hear us talking about crosslinking and the three big things. One is riboflavin. That's the ingredient, or sometimes you'll hear us call it the medication that's needed. Ultraviolet light, and then oxygen. And you need those three things to make crosslinking happen. The big thing to know is this is not a refractive surgery. It's more a stop the progression. So it's a treatment. So it doesn't correct your vision or cure the keratoconus. But what we're really trying to do is slow or halt the progression of the cornea. And I would say 99% of the time it stops it. But the times where it doesn't is if people continue to rub their eyes or continue to pillow dive, or, you know, they can't get control of their allergies, and that overcomes sort of the crosslinking process. and that's with the epithelium off cross-linking, and we'll dive into the specifics here in a little bit. But you still need, your routine care and follow-up to make sure nothing's progressing, there's nothing changing, and the goal is to keep you in your current vision correction, whether it's glasses, soft contact, or a scleral or special contact. And sometimes you can pair it with other things to maybe lessen that burden a little bit, but you're still going to need some form of vision correction. It's FDA approved for people aged 14 and up, but you can do it younger, and obviously you can do it older. And Brooke, I'm trying to think how many patients we do that are sort of off-label, and what that means for the audience is when something gets approved through the FDA, that's what we call on-label. It was approved for patients 14 and over. The stuff that's in the news now and is like vaccines and things like that. What does FDA approval mean? But in the eye world, we do a lot of stuff sort of off-label, and it's not because we're taking a risk or gambling or anything like that. It's just we know that's what's best for the patient because of other studies or clinical evidence and stuff that's available that just is sort of outside the FDA approval. So sometimes we'll do that in younger patients because in our minds, in our world, and if it's my eye or my kid's eye and they're 12 years old and they've got keratoconus and it's progressing, I'm not going to wait 2 years to treat them. I'm going to treat them, right away. And so, so just because they're younger than what's the FDA approved age doesn't mean they can't have cross-linking. And then there's a small subset of patients who've had refractive surgery that then go on and who develop keratoconus or progressive ectasia, and their findings are similar but a little bit different, and they're also eligible for cornea cross-linking. Brooke, did I miss anything?
No, I was just going to say that thankfully with the increased use of tomography through Pentacam or Orb scan, we're picking up on those thin corneas, those abnormal posterior cornea changes. And so thankfully we're seeing less and less post-refractive surgery keratoconus or secondary ectasias. So again, they're out there, but we're seeing less and less, thankfully.
Yeah. Oh, go ahead.
Or I was just going to talk about the pre-op because then the surgery is next. So I'm going to have you talk about that.
Perfect.
For when we see patients for a consultation visit, it's going to be a similar visit to the screening that we've already talked about. So you'll have a Pentacam done. We'll measure pachymetry. We'll do a good slit lamp examination. If we wanted to find anything more about your cornea, we might do an anterior segment OCT. I won't say that that's an essential to that first visit. Really the key piece is having that tomography comparison so we can see the front and the back cornea, so that we can confirm the presence of that corneal ectasia. And on the day of your procedure, when you come in for your cross-linking, at our clinic, we offer a relaxing medication, maybe like a Valium or something, just so that patients are more comfortable when they're having the procedure, because it does take about an hour. We encourage them to wear comfortable clothing. Our team is very talkative and very chatty, and they certainly keep that hour moving along. I know other practices will welcome patients to bring their headphones along so that they can listen to a podcast or something like that, just to help keep that hour moving. Afterwards, because we do remove that surface layer of the eye will be a bit sore, so we encourage you to go home and rest. And depending on the eye and your history, we'll plan on doing the eyes 2 weeks to 1 month apart. Eyes that are less severe, when you think about the cornea being a dome versus a tall cone, I have learned that the more severe the keratoconus, the slower that healing process tends to be. And so if I have somebody with moderate to advanced keratoconus, I'll encourage them to schedule their keratoconus or their cross-linking about a month apart. More mild cases of keratoconus, maybe these patients are still able to wear glasses or soft contact lenses. We're just able to pick up that keratoconus on the scans. Then 2 weeks apart is pretty easy for them. They heal fairly quickly because those epithelial cells are growing more across a field versus up a mountain. And the cells tend to settle into place a bit more quickly, and they can be, more functional with the first eye 2 weeks later, and then have the second eye done, where again, the more advanced ones, they do need that month for that first eye to see well enough so that they can have the second eye done.
Yeah, and you touched on it a little bit, but kind of repeating or confirming some of the testing. Sometimes we have to do that for insurance purposes, and the cross-linking procedure, like I said, it was approved in 2016, so it's been around since then. Initially, it just takes time for insurance to get on board with this, but at this moment, it's pretty broadly accepted by insurances. And so if you've talked to your doctor and they say like, well, I'm not sure if insurance, is quite covering it, make sure you follow up with that, because I'd say, it almost has universal coverage now. Mm-hmm. And coverage means different things. It doesn't mean that it's not going to cost anything, but it does go covered through your insurance. And so it should be a service that can be provided to you. And sometimes it depends on your insurance and in your eye. There's certain requirements and things that you need to meet. But usually where practices are pretty familiar with what needs to be done ahead of time. So the procedure itself, the way we perform it and how most places perform it is the FDA approved method. This is sometimes referred to as the, I'm blanking on the protocol.
The Dresden, I think.
Dresden protocol, thank you. Yeah, Dresden is the area where it was first founded. So the Dresden protocol, which is to date the most studied and has the most effectiveness, meaning the patients that have it performed this way are least likely to progress compared to other ways that have been treated, either with leaving the epithelium on or shortening the treatment by increasing the intensity and different things like that. But now there's evidence and different techniques that are coming out that are catching up to this that'll hopefully make it better. But this is kind of the way it's performed if you had cross-linking today or tomorrow. And so as Brooke mentioned, we get you nice and relaxed. We give you some relaxing medicine if you'd like it. We gently remove the epithelium from the eye. We've numbed it already. You're laying flat. In our case, we do it under our laser bed. But you're laying flat, you're comfortable. They put an eyelid holder in the eye, so you don't have to worry about blinking or anything like that. You can close and relax your other eye. We remove the epithelium. Sometimes we use a medicine that stings a little bit to help take it off. And then the Photrexa or the riboflavin is dosed to the cornea for 30 minutes. And then you make sure that it's fully saturated. And then we use an ultraviolet light for 30 minutes. Again, when they're giving you the riboflavin drops, they don't have the eyelid holder in, so you can close your eye during that process. But when the light is on, they like the eyelid holder back in the eye, so you don't have to worry about blinking or anything like that, and you just kind of stare off into the distance while you're looking at the light. You can have a conversation with whoever's helping perform the procedure, or have your headphones in, as Brooke mentioned. And then every 2 minutes you get an eye drop, and there's a little timer that goes along the machine that helps remind everybody when it's time to do that. And then after the procedure is done, we put a bandage contact lens on to help for the healing and with the discomfort. We usually do just one eye at a time, as Brooke mentioned, but in certain cases, patients aren't able to lay still, they need general anesthesia, stuff like that. We'll go ahead and do both eyes at the same time. But the recovery is a little tough sometimes, and so that's why it's hard to do both eyes. But we'll talk about that here after we answer some questions.
Yeah.
If we've got it.
while the questions are rolling in, Dr. Chiu had just asked us to mention about like some of the, epithelium on is a buzzword out there, and there are some people doing it, but it's, it's not the FDA approved method, and we don't do epithelium off or epithelium on, excuse me. It would only be if we were doing it through maybe a clinical study, but routinely we do not do epithelium on cross-linking. And one of the messages we wanted to get across tonight was, the FDA approved method is, currently the gold standard. And so if you're in the clinic having a scan or having a consultation, you should ask, what type of cross-linking will I be having? Is it the FDA approved way? And then that is the only way that would be able to go through your insurance as well.
Yeah, and the reason for that is the machine that we use, the iLink procedure, the parameters are set. We can't dial up the light or anything like that. And so, we just have to, we hit go and the machine does its work. So if you leave the epithelium on, you can't get the oxygen to the cornea, like we mentioned before. That's kind of the catalyst that needs to be present for the procedure. One of our locations is in the study. I think it's done, and they're just wrapping up the data on it. But hopefully in the next year or so, the data will be available where it is epithelium on, but you're wearing goggles that kind of pump oxygen in and hypersaturate it. And that allows that to happen with the epithelium still being on, and it shortens the treatment time, and it makes it a little bit safer procedure and a little bit more, and the same efficacy. But if you just did epithelium on now with our current protocol, the combination of the ultraviolet light and the oxygen and the riboflavin just isn't right to halt the progression. And so that's why we like to do it this current way.
Well, thank you so much for that really wonderful, helpful, and detailed overview of keratoconus, as well as all of the information about corneal cross-linking. And you were touching upon the fact that there is an improved FDA version versus other protocols. So we have a lot of interest from our audience today, and we have a lot of questions. So maybe we can spend the next 10 minutes on it. Then I know you have a couple more slides to finish up your talk.
Yeah, and we'll just some post-op information.
Perfect. So as you discussed already and mentioned, eye rubbing is not healthy for these patients, particularly with keratoconus, because it can make the condition worse. So we have a patient who's saying, I tend to rub my eyes a lot and then it becomes very dry. Do you have any tips for preventing rubbing and helping to soothe their eyes?
I usually talk about cold compresses, allergy eye drops. If you have a lot of systemic allergies, visit with an allergist or your primary care physician. Again, lubrication eye drops, things like Restasis eye drops that can help you make more of your own tears. Really, the key is to decrease the friction of the eyelid against your cornea, because that's what sort of stimulates that itchiness. And so it's kind of like a dry eye protocol, even though you may not have diagnosed dry eye, but we know that patients with keratoconus tend to have more allergic presentation, and those are things that can help reduce that.
Are there any medications you may prescribe to help with the itching as well?
Something over the counter like a Pataday would be good to pick up, or a Zatador, and those are both over the counter, easy to get. That's where I would start. Prescriptions again would be, there's like mild steroids, and the Xiidra or the Restasis type things. Am I missing anything that you were thinking of, Gloria or Mike?
No, I just thought that maybe hearing some of those examples, whether it's prescription or over the counter, patients can pick up. And I think the neat thing is that, recently there's a lot of over the counter good allergy topical medications that are available now, whereas before it was really hard to get through insurance coverage and the cost was high. Yeah. And I think so we have Pataday, and also Lasticaft is a new one that became over the counter. And there's also a preservative-free aloe now. So we're having more and more options.
You can't see it, but I put my hand up. I bought preservative-free aloe yesterday for myself.
For yourself?
Yeah.
And how do you like it?
It's been great.
Great. So
the vial, so this is a nice tip. The preservative-free ones come in a little vial, and it said a 10-day supply on it. I was like, well, man, that's not very convenient. But I got 3 days out of one vial. So the vials, you know, some people might want to say, please stop talking, but if you crack the vial, keep the cupboard clean, keep it in a safe spot, you refrigerate it, you can put a drop in and there's still a bunch left in the vial and you can use it later on. So, but just be careful with that because you don't want to contaminate anything. But if you keep it clean, you can get a few days out of it.
Okay, good, some practical tips. So another audience member said, I'm having my second corneal transplant in my left eye next week and told that my disease in the right eye is progressing very slowly. Why is one cornea worse than the other, and what could be causing this with keratoconus?
I'll start. You know, keratoconus is a funny thing, and as we mentioned, there's a lot of factors, and you know, it's usually asymmetric, meaning one side progresses more than the other, and it can be just how you were put together. It could have been from rubbing an eye more than the other, or sleeping on one side more than the other that we mentioned. And it could just be that's how it is. But what we know is the disease process, without knowing your case. But you can get progression of keratoconus even after the cornea transplant because it happens, you know, so far in the periphery, and Brooke touched on it at the beginning. These fibers kind of run all the way across the white part of the eye to the other side of the white part of the eye, and so that can kind of progress a little bit even after a cornea transplant. But you know, we wish you luck on that second transplant and hope that right eye continues to move slowly. And if you have the opportunity to get that one cross-linked so you don't have to go down the same pathway, that would be great.
For sure.
Great. And I think that's a great tip that you just said, that so you don't have to go down the same pathway. Cross-linking is something that we can offer to our patients sooner so that hopefully they won't need to have a corneal transplant. And I think that's the goal for a lot of us, that now we have something that you said in your talk to halt or slow the progression. And now we're not doing as many transplants because we have access to this treatment earlier. So thanks for that. So do you have any tips? You had mentioned also, rubbing and pillow. Do you have any tips on protecting the eyes during sleeping when, you're inadvertently rubbing them at nighttime?
Vance of Vance Thompson Vision at our Sioux Falls clinic, he actually, for patients that are at really high risk, he tells them to get goggles. He sends them to a sports store and gets goggles. That is an advanced or a aggressive way to do it, other than like sleep training, having maybe like pillows around you to stop you from rolling in ways and things like that. But if you are at risk for keratoconus or have it and you think you might be doing some of those things, I guess if it were my child, I would consider that. I guess, what else do you think, Mike?
Yeah, I mean, I think that's a great way to do it. I think just being aware of it and being conscious of it. The previous question on saying, I know I rub my eyes a lot, just knowing that you're doing it, it can cause you, harm. That's a step, and now that starts to go from unconscious or subconscious thought to conscious, and that'll just help. So just knowing it and being aware of it and paying attention to it, I think can really help.
Yeah, totally agreed. I think that's the first step, to acknowledge that you do rub your eyes and then work on trying to avoid it. Because, there are some patients that I've heard stories of where, they put the goggles on, but somehow when they wake up, they're on the floor or across the room or under their pillow. So, I think you can only do your best. Some have even tried to tape the shields to their face so that they won't fall off, but sometimes the tape can bother them or come off. So I think it's really about finding the best technique that works for you. It may not be goggles for everyone. It could be just maybe even taping your eyes closed, but kind of just working with different techniques and seeing which one sticks.
And I guess, making sure the eyes are lubricated, treating any dryness, making your eyes comfortable will really help keep your hands away from them too.
Yep, good tip. Let's see. One more question, and then I'll let you finish up your slides, and then we'll take a few more. So is cross-linking safe and appropriate even if you're older than 65?
I would say yes. You know, the one thing that we know about the aging eye is that we're more dry. And so we may do things like punctal plugs or lubrication drops or, you know, something like that, Restasis or Xiidra. Or there's even medications or things we can do after cross-linking to help you heal more efficiently or more quickly, you know, even as far as like an amniotic membrane, which is like a membrane that goes across your eye to help you heal. It provides nutrients to the front of the eye. But yes, if, you know, to me, it's if you're, you know, it doesn't matter what your age is, if your keratoconus is changing, then you should be cross-linked. There's kind of, you know, Mike has mentioned it before, there's kind of an apex of the hill that your keratoconus might move slowly and then you kind of cross over and all of a sudden you change rapidly, no matter what your age is. You know, typically keratoconus slows down with age, but not always. And so yes, it is safe to do.
And the good news is your body will kind of naturally cross-link as you age. So if you're older and your keratoconus is stable, that doesn't mean, you know, nothing's changed, your prescription hasn't changed, cornea is stable. You don't have to go get cross-linking done. But if you're older and it's progressing, then of course you want to address it. So good news if you're, you know, continuing to age.
And I think to, you know, add to that, we know that there's two approved indications for cross-linking, and one is progressive keratoconus, the other is ectasia following refractive surgery, such as LASIK. And, you know, as Dr. Messer said, you know, generally the onset of keratoconus is in the younger ages and teens and 20s, and that's where, you know, most of our, you know, doctors now are probably cross-linking keratoconus patients. But with some of the post-refractive surgery LASIK cases, you can still get changes in your 50s or 60s. And I've had one patient that I referred for cross-linking in her either late 50s or early 60s because there were some changes in her post, you know, LASIK cornea. So, you know, if you are older than 65, obviously we want to just still make sure that there are changes that indicate the treatment. And if, you know, we're treating the eye and addressing the dryness and providing the right pre and post-op experience, I think you'll be in good hands. And that kind of segues into Dr. Messer's slide here about post-op experience. So why don't you continue?
We just have a couple more slides and then we can take more questions. As you can imagine, when we basically induce a cornea abrasion by removing that epithelium, your eyes will be irritated, and it takes about you know, 3 days for the new cells to cover, you know, 2/3 or more of the cornea to where that sensitivity starts to decrease, and your vision will be blurry. Those new cells are irregular and bumpy, and it takes a while for them to grow in and smooth out. There's a bandage lens placed at the end of the procedure so that you remain comfortable, or, you know, to improve your comfort. And that'll be removed by your optometrist or ophthalmologist somewhere between 4 or 5 days to 7 days after the procedure, basically when those epithelial cells have covered the entire cornea again. And because, again, those new cells, it takes a few layers of those new cells to grow over the cornea to really smooth out your vision. So I like to say that each week you should see a step improvement in your vision. And there may be a little bit of fluctuation, but do always, you know, give your doc a call if you experience progressive worsening. Fluctuation is one thing, but if you feel like your vision's getting worse or your pain is not getting better, then you should give us a call. You know, we'd much rather reassure you than have to deal with something that was non-healing or, you know, going backwards. So don't be shy. The next set of healing is how that epithelium or those new surface cells remodel. Some patients get concerned at that 3 to 4 week mark, because when we repeat measurements, we actually see that it looks like the keratoconus is getting worse. But it's actually because of the way those epithelial cells regrow, and that it kind of emphasizes the cone at first before it smooths out again. So it's a false steepening of the cornea as the epithelium remodels, and Dr. Greenwood is going to talk through the next slide to kind of expand on that a little bit. Or sorry, this one's mine, and then Dr. Greenwood will take over. This is just go one more. Sorry, Mike. This is just an anterior segment OCT, and I just wanted to highlight the epithelium is in between the arrows there, and there's actually a little bit of epithelial hazing, and so that would be removed in this process. But if you look to the right of the cornea, you can see the epithelium is thinner, and then in the center it's a little thicker. And in keratoconus, we know that the epithelium varies in thickness, and that's why it when it grows back, it's more even, and it takes a while to kind of obtain that similar non-regular shape in order for your vision to get back to kind of its normal normal state of blurriness, I guess.
And yeah, so the epithelial remodeling, just briefly on this is, you know, we remove all the epithelium, it has to grow back in. So if you think of, you know, your lawn, that, you know, if you, we got a swing set in our backyard, so where the kids swing, that stuff all gets kind of wore down, and if they stop, then it would slowly grow back in, and it just takes a little bit of time. And that's kind of how it works on the surface of the cornea. But it all grows back in, and then the cells meet in the middle, and they make this big ridge, and then they got to settle down and kind of find where they fit. So it just takes some time, and so that's why it gives kind of this changes in your vision. So the irritation is while it's healing, and then the change in the vision is everything just kind of settling and finding its new spot. And so that's why your prescription might change just a touch over that 3 to 6 months once everything is healing. And then long term, you know, we check people, you know, a few days after the procedure to remove the bandaged contact lens, a couple weeks after that to make sure they're doing well, and then at 3 months, 6 months, 12 months, again, depending on how severe you are and how much you should be monitored, but at least every 6 to 12 months, at least in that first year to 2 years. And then as things become to be more stable, you can lengthen that out a little bit. And as Brooke said, you can get back into new contact lenses, usually within a few months after the cross-linking procedure. And that's one of the studies that her and I are actually looking at doing is, you know, what happens if you did contact lenses a day after? What happens if you did it a month after or 3 months after? And so hopefully we'll be able to provide some answers that are a little bit more clear-cut with that. Last slide, or I think maybe, is you know, these other conditions that can be involved with keratoconus, in case you haven't heard of, but floppy eyelid syndrome and sleep apnea. The lids just get real floppy. It exposes the cornea, it makes them dry. You want to rub them. Hydrops, mitral valve prolapse, again, just kind of loose tissue problems. Vascular diseases with the collagen tissue, again, to connective tissue disorders. These are all related to you know, connective tissue related to the cornea and other structures throughout the body that can be affected. Family members, if you have family members with keratoconus, you know, consider yourself at risk. If you have it, consider your family members at risk, as we mentioned. And again, we have a treatment. That's why it's so important. It doesn't fix the problem, but it stops the disease. You want to keep your vision where it's at. Don't wait for it to get worse, and then be patient during the post-operative process. Few days of stinging and burning, and it can be pretty tough and pretty sensitive to light, but hang in there. It will get better, and then be patient as the vision's going to fluctuate, you know, daily as everything settles in, but eventually we'll get to a good spot and hopefully be less worrisome because you know that your cornea has been strengthened.
Great. Well, thank you so much for that. We only have 4 more minutes left, but I want to try to get in maybe 2 or 3 more questions. So in regards to kind of relationship with some other conditions, have you seen changes in keratoconus or the corneal shape after cataract surgery?
I can't say a ton. You know, maybe if the incision was at a particularly thin spot. So I wouldn't say it's like particularly concerning, but they should still be monitored, you know, just like you normally would.
Yeah, usually not a whole lot of change. Our cataract techniques have evolved so much that it's, you know, minimally invasive, so to speak, so it doesn't really impact the cornea.
Got it. Similar here. I haven't really seen progression, and I don't think there's really any cases in the literature reporting progression after cataract surgery. So But interesting question. Another, can you have cross-linking done if you have early glaucoma?
Yeah, that's a great question. Short answer is yes. You are on a short course of steroids after the cross-linking procedure, but it's not strong enough or long enough that it's going to cause your pressure to get higher. Sometimes steroid medications can make glaucoma patients' pressure go up higher, but yes, very safe to do.
Great. And you touched upon this in some of your slides, but do you have to repeat cross-linking surgery in the future?
I'll take this one. You can. We have. I think we've done it for 1 or 2 patients, excuse me, that have the epithelium off procedure, but I think they were heavy eye rubbers, and we have done it in 1 or 2 people that on cross-linking that had progressed a little bit, but it's very rare, but it's possible because of the reasons we mentioned. You just can't overcome the mechanical force of rubbing.
Agree. I think in our department as well, there is one I know of who I also see, and she had the Epi-on protocol, and after that we noticed progression, and then we had the FDA approved version done in our clinic. And so I think it also depends on which protocol you had done. So I think it's important to verify with your provider what type of cross-linking procedure are they doing with you. And why don't we end on an insurance question? So, you know, obviously this is an important subject matter to patients. It can be costly to have this procedure done in both eyes. One audience member said, my insurance only covered it once I hit 24 months of diagnosis, but it was progressing fast. How has your experience been with insurance coverage?
Thankfully, ours has been really good. You know, we used to have to submit documentation of change through various parameters, whether it's refraction or cornea findings. And now our insurance team is reporting that sometimes they don't even have to send that in. And so, you know, we're grateful, at least in our area, that plans are covering it. And, you know, you just want to go in there and shake some heads being like, this is so much less expensive than a corneal transplant, you know, big dummy.
Oh, what we would like to say to the insurance people sometimes. Well, if you could move on to the last slide, I wanted to, first of all, thank you, Dr. Greenwood and Dr. Messer, for your time this evening and sharing so much knowledge with all of us here at the National Keratoconus Foundation. And to the audience, thank you so much for joining us and spending this hour with us. Our next evening webinar will be on Tuesday, July 12th, and the topic will be IV Med 85 eye drops for the treatment of keratoconus. So really excited to learn about that. And again, thank you everyone for your time this evening. I hope you have a wonderful rest of the day, and we look forward to discussing and sharing more about keratoconus in 2 months. Have a great evening, everyone.
Thank you.
Thank you.
Bye.